All right, let's continue with our lectures. This lecture is going to focus on aortic aneurysms. Now, what is an aneurysm? An aneurysm is simply an outpouching, a weakening in the vessel, in this case, the aorta. And I have to remember that the aorta is going to branch off of the heart. And again, it's going to be the major source of blood supply to the organs, to the kidneys, to the GI tract, to extremities. Remember also that off the aortic arch, you're going to have the carotid artery, so that blood supply is going to go to the brain. So here we have a regular artery, regular vessel. Okay, so if I were to switch that, it's going this way instead of turning it around, looking straight at you, you have this shape here. Now, in a aortic aneurysm, again, you have an outpouching, something like this. Or if we were to turn that blood vessel around, having it look straight at us, we might have, again, an outpouching like this. So again, blood is supposed to come here and exit through here. But for an aneurysm, blood may come here. It may actually circulate around here. And one of the things that we always worry about with aneurysms is if this aneurysm were to rupture. That is a big problem for this patient. Now, aneurysms, you'll find them in about 3 different locations. One, in the aortic arch up here. Number 2, in the thoracic cavity, chest. So remember, if I was to draw a line through here, you'd have your diaphragm through here, lungs through here. Okay, so this would be in the thoracic cavity. So you could also have an outpouching through here. Or if this was an abdominal aorta or abdominal aortic aneurysm, a AAA, it would again happen in the abdominal region, here or here. Now again, an increase in the aortic aneurysm also increases the likelihood of it rupturing. Now, what are some causes of this aortic aneurysm? Biggest thing is atherosclerosis. We talked about how atherosclerosis is a plaque buildup in the arteries. So for example, if we were to have plaque buildup here, it's going to cause a narrowing. And remember that you're also going to have macrophages, platelets coming in, trying to repair that weakened area. Now, with this plaque formation, or maybe it's cholesterol that has been deposited in this vessel over time. Now, as this size gets smaller and smaller, one thing that's going to happen is blood pressure is going to increase in this area here. That increase in blood pressure at some point can cause that weakening to occur, or that bulging to occur. So we have a combination of causes that will result in an aneurysm. Number 1 being atherosclerosis. Number 2, hypertension. Again, increase in blood pressure is going to cause a weakening in this blood vessel, in this case the aorta. Number 3, increase in cholesterol. So if you have increased cholesterol levels, again, that's going to cause a plaque formation in the blood vessel, again causing a narrowing. Smoking, remember, causes vasoconstriction. Vasoconstriction will result in increased blood pressure. So all of these things will again have an increase in the amount of blood pressure. And again, that increase in blood pressure throughout time has a potential of causing an aneurysm. Also, in an acute form, for example, a patient suffers an MVA, some type of trauma, and has a blow to the thoracic area or to the abdominal area, if it is severe enough, strong enough, it can cause a weakening to the aorta. So those are again some brief causes. Let's focus on some clinical manifestations that you will need to know for your Nclex exam. Number 1, chest pain. Now this chest pain, depending on where the aortic aneurysm is, for example, if it is in the aortic arch or in the thoracic region, patients will typically complain of chest pain radiating to the back. This will be severe back pain as well. You could have something as like angina or angina. Now this will be due to decreased blood flow. Remember that if you have Anthro Sclerosis, one of the areas that may be affected are the coronary arteries. So if you have a decreased blood supply to the coronary arteries due to atherosclerosis, you're going to have decreased blood flow to that area, decreased blood flow to the heart, causing chest pain. The biggie that you need to remember for the Nclex exam is the pulsatile mass in the umbilical region, or periumbilical region. So if you see a pulsating abdominal mass, that should turn on a light switch in your brain indicating aortic aneurysm. Now if you were to auscultate this, you would also find that you'd find bruits present. Okay, so pulsatile mass along with bruits present upon auscultation. Again, this will be to the periumbilical region. Now what are some complications of the aortic aneurysm? Number 1, rupture. Now if this were to rupture, this has a 90% mortality rate. So this is a medical emergency. Now death will occur due to severe hemorrhage. So again, you want to be very, very careful with these patients. Now number 2, or most likely number 1, hypovolemic shock. Now with hypovolemic shock, you'll have tachycardia, increase in heart rate with a drop in blood pressure or hypotension, because again, you're bleeding out, therefore your blood pressure will fall, your heart rate will increase in order to sustain adequate cardiac output or adequate blood supply throughout the body. So that is why you will have tachycardia. Now because you have no blood going to your skin, you'll have pale, clammy skin. We'll focus on decreased urine output later on, but also remember you're going to have altered mental status because again you have no blood supply to the brain. Now what are some diagnostic studies? The most accurate diagnostic study that can be performed is a CT. Most likely CT, chest, abdomen, and pelvis with IV contrast. Now, if this patient is going to have IV contrast, you must ask your patient if they have any allergies to shellfish. Is their BUN and creatinine within normal limits? Are they diabetic? If so, are they taking anything like metformin, glucovans, glucophage, glyburide? Because again, that is going to have an effect on that patient receiving IV contrast. If they are, again, you must inform that patient to withhold those diabetic medications for that day, and then again 48 hours post. Okay, so diagnostic studies, number 1, CT. You can also do MRI, ultrasound, but again, number 1 most accurate diagnostic study is the CT. Now what are some treatments, interventions for your patients? Number 1, therapy should be focused at decreasing blood pressure, because again, if you have a patient that has increased blood pressure, one of the complications that you run into is with having the aorta rupture, the aneurysm rupture. So again, you want to control blood pressure. You want to bring it down, making it less likely for that aneurysm to rupture. Number two, if it is known that the patient has a aneurysm, then you want to monitor the size of that aneurysm. So these patients typically get CT scans on a regular basis, depending on what the physician orders. Now, if they're going to get some type of surgical therapy, the size of the aneurysm for men must be greater or equal to 5.5 centimeters. Again, that's for men, and in women it must be greater or equal to 5 centimeters, and again, that is for women. If they're smaller than that, then typically they'll just monitor them. And again, you're wanting to control blood pressure. So if it is bigger than these, then surgical repair will be performed. Now we'll focus on our interventions and not so much on the surgery. Okay? Because remember, for the Nclex exam, you're most likely going to be tested on your interventions. So make sure we have our interventions down. So we have surgical repair, or something like an endovascular graft procedure may be performed. Now in the endovascular graft procedure, you remember that you're going to be going in through the femoral arteries. Now with the endovascular graft procedure, you must know that one of the common complications is something called an endoleak. Okay. Something else you have to worry about is a stent migration. So the graft that is put in can actually move throughout the aorta. Now this is a complication because it may cause an occlusion. We'll talk about this when we talk a little bit more about our interventions. You must also monitor the incision site for infection. Like I said, we're going to be going in through the femoral arteries. So you're going to be checking for redness, tenderness, increase in warmth, any discharge. You'll report that to the physician immediately. Now again, you will do, or the physician will most likely order routine CTs to see if the procedure is effective, if it is successful. Now with the graft procedure, the other thing that you want to worry or look out for are graft thrombosis. Again, the thrombosis, the occlusion, may be due to the stent moving or migrating. So again, you always want to assess your patient very, very carefully. Now, if you're going to be preparing a patient for surgery, again, you must remember to place your patient NPO status, bowel prep kit. You'll most likely also start them on IV antibiotics pre-op. Again, this will be determined by the physician. Be prepared to put your patient, again, NPO, do a bowel prep, and again, start IV line and administer IV antibiotics. Now, post-op, typically these patients will be in the ICU 24 to 48 hours post-op. You will make sure that the patient is on telemetry. You monitor their O2 sats, so put them on a continuous O2 monitor. Again, we're dealing with the aorta, so we want to make sure if there's any changes in their O2 saturation levels, it could be indicative of a bleed. Again, if there is a bleed going on, there might be some EKG or telemetry changes. So by putting them on a continuous monitor, if you're putting them on telemetry, that'll let you know, again, if there are any changes occurring. Now, if surgical repair was performed and if the thorax was open, most likely this patient will be on chest tubes, or will have chest tubes in place. So again, you always want to assess O2 sats, check to see if there's any difficulty breathing. You always want to take care of their pain, make sure that their pain is well controlled. Depending on the physician, they may place the patient on a PCA, or they may place him, they may have a epidural in place to control the pain. But whatever the case may be, make sure that the pain is well controlled. If it is not well controlled, it'll be more difficult for that patient to breathe. If it is more difficult for that patient to breathe, it'll be more likely for them to acquire pneumonia or atelectasis. So make sure again that that pain is well controlled. You will monitor their urinary output. You will monitor for dysrhythmias. We'll focus on urinary output here shortly. Again, you will focus on blood pressure. You want to keep blood pressure down. However, you do not want to cause severe hypotension. You cause severe hypotension, you run the likelihood of causing blood clots, because then again the blood is not moving like it should. So yes, you want to control blood pressure, but you do not want to drop it down too low. At the same time, you do not want to cause hypertension. This patient just had surgery on the aorta. You have high blood pressure, you run the risk of causing rupture of the suture lines. So again, you want to control that blood pressure very, very well. So this patient may have some drug therapy like Lasix, labetalol. Again, the labetalol will be to control blood pressure. Lasix to rid the body of fluid. If you're giving labetalol, again, always pay attention to blood pressure. Always pay attention to their level of consciousness. You don't want to drop blood pressure down too low. Most likely, again, the physician will order some type of antibiotic therapy. So, along with the antibiotic therapy, you want to monitor their WBC. If there are any increases, you want to report that to the physician immediately. Again, if they had some type of thoracic surgery, you want to make sure you catch the infection at an early stage. If they have an NG tube, you want to make sure that it is in the correct location. Auscultate, pay attention to the stomach contents. You will always assess for bowel sounds. Make sure that hopefully there is no ileus present. So you always want to monitor again for those bowel sounds. Ask the patient if they're passing any gas, and you want to ambulate your patient right away as soon as they can. Again, you want to get those bowels moving again. So ambulation will help that. As always, medicate your patient appropriately with pain. It'll make it easier for them to ambulate. Again, you will assess their level of consciousness. You will assess their pupils. Make sure they're alert to time, place, location. Again, any changes in their level of consciousness could be an indication of bleeding. You have surgery in the aorta, again, you have the potential for large amounts of blood loss in a very short amount of time. So again, always assess your level of consciousness. You will also assess their pulses, carotid, radial, femoral. Report any changes to the physician immediately. Decreases in pulses with pale skin, cool skin, maybe pain to the extremity, may indicate some type of emboli, some type of occlusion, or maybe, again, the graft moved and the graft is causing an occlusion. So if an embolus or an emboli is present, some type of thrombolytic therapy may be required. So again, you're always assessing your patient. Cap refills. Again, what is the color of their skin? Is their temperature decreasing? Any pain present to that extremity? Now, urine output. Why would you monitor urine output? Well, depending on what surgery was performed, depending on where the occlusion may be, if, for example, the renal arteries are occluded, that's going to decrease the amount of blood to the kidneys. If you decrease the amount of blood to the kidneys will shut down. If the kidneys shut down, you will have decreased urine output. Most likely your patient will have a Foley in place. So again, you always want to assess for the amount of urine produced. You will also monitor your BUN and creatinine. If these become elevated, it can be indicative of some type of renal pathology or decrease in renal function. Now, when these patients are getting ready to go home, you will inform them to avoid heavy lifting for a minimum of 6 weeks. Again, they had abdominal surgery. aortic surgery, you do not want to open those suture lines up. So again, you will want to avoid heavy lifting. You will also educate your patient to monitor their pulse, look for changes in their skin color, temperature, any pain, any loss of sensation. Again, you will have them report that to the physician immediately.